Hello, my name's Rob Greig. I'm Chief Executive at the National Development Team for Inclusion. We're a not-for-profit organisation in England concerned with ensuring that disabled and older people are able to live better lives in their communities. I've been asked to talk with you today about personalisation, with particular reference to people with mental health problems and how that's going in England. I'm very conscious in doing that people watching this will have different knowledge and experience of personalisation, so I hope those who are more familiar with it will bear with me as I give a little bit of background before going on to talk about our experiences. I've been involved in personalisation for a long time. I was involved in some of the early discussions, so in many ways I'm a great supporter of it, but I have to say I'm a bit concerned about some of the ways in which it's developing nowadays, and I'll share that as I go along. So in terms of what personalisation is, well, at its most simple, it's about people receiving the support and the services that they want. Things that are based upon their voice, their choice and their control, rather than being determined by services themselves. And crucially, it's about those services supporting people to live a life in their community and have a real life. Many people would say that's what good services do, and I would agree that's what most services try to do and what most staff try to do. But if that were the case, then why do statistics tell us that people's experiences are different? For example, from NHS data, just over half of people say that services do take their views into account, but that means nearly half say that they don't, and over half of people say that the goals that they're set don't really meet their needs. If we look on whole life figures and statistics, then why are around 2.3 million people with mental health problems not in work, with only 8% of people with serious mental health problems in employment, a figure that is going down? Clearly things aren't working that well. So personalisation at its core is about a transfer of power from professionals to people, from services to communities. And as part of that, a crucial bit is people getting control over how the money is spent so they can assert real authority. Now, this is a journey that's been going on for a number of years. It has its roots in the fight of disabled people for self-determination. But around 15 or more years ago, people in England in particular began to be concerned that the service systems didn't enable people to get real choice and control over their services, and there was a growing concern that the quality wasn't good enough, and so the personalisation debate began to emerge. That means that nowadays, in England and indeed much of the UK, personalisation is the underpinning policy expectation of the social care system. It's also an expectation of the National Health Service, but it's fair to say that it's not a high priority, and that's an issue I'll come back to in a minute. But there are some real concerns that personalisation is losing its way because of a combination of an over-focus on system mechanisms, the setting of targets that encourage people to focus on the wrong things, and the difficulties of implementing such a major change and shifting culture at a time of financial cuts. But where it is working, it's working pretty well, and the things that are important to that, there's really a five-stage process. Firstly, people are supported to plan for their own lives, the start being what people want and need, not a disability deficit model. Planning being led by the person, not by the professional. And importantly, having a social care mindset, that it's about life, not about services that decide what people get and receive. Secondly, people are then told how much money is available. The principle being that it's not based upon their disability, it's based upon need and aspiration. There's a difference there, and there's a system often called a resource allocation system that decides how much money somebody is able to have. Then people are supported to develop a plan that meets their needs, and that is not about defining traditional services, it's about saying what things will make a difference, and importantly, what support they need to be able to put a plan in place. Concepts like brokerage are fundamental to personalisation. Then people are given control over the money. This is often where the big debate around personal budgets begins to take everything over. People can take complete control of that money if they want to, or if not, then the council will keep on managing the money on their behalf. But of course, listening to what they say they want the money to be spent on. And there are various reasons or various ways within that things can be done with differing levels of control that people have, like family trust funds, for example. But again, the access to independent support is crucial for it working. And the final stage, obviously, is that people then get the supports that they want and need. And often those don't look like traditional services. They can be mainstream activities, things that help people get a life. If we look, for example, at the sort of things people spend their money on, yes, it's quite often personal assistance, staff in another word, but personal assistants to help them do the things they want. But there are a range of other things like support around leisure, everyday tasks, gym membership, computing, IT, travel, education, volunteering. Interestingly, one thing people are tending not to spend their money on at the moment is to support to get into paid work. And there are some interesting and complicated reasons as to why that is the case. So how's personalisation going? Well, about 5 years ago, there was a survey done called the Ibsen survey in England, which looks at the early pilots. It was cross-client group. There was a bit of support to make sure it worked effectively. So what did that tell us? Well, here are two examples. So the graph that I hope you can see on this presentation at the moment talks about social care outcomes for people with mental health problems. Put simply, the dots above the line show that people were having better outcomes, those below worse outcomes. And the dots to the right of the vertical line say that services were more expensive. To the left of the line, they were less expensive. You can see the overwhelming majority of people were getting better social care outcomes. Some cost more, some cost less, but overall the cost was basically neutral. Here's another similar graph. This is looking at psychological well-being for people with mental health problems. Again, the overwhelming majority above that horizontal line, so there were better outcomes. Costs varied, costs basically neutral. So some practical research evidence showing that it's working quite well. Coming up to date a bit more. In 2013, work done by Lancaster University called the POET survey showed that over 70% of people with mental health problems got a load of positive outcomes, getting the support they want, being supported with dignity and respect. Around 60% of people reported positive outcomes in areas like physical health, mental well-being, control over important things in life, control over their support. There was less than 10% of people who were actually reporting negative outcomes in any area of their life. A couple of final specifics. In West Sussex, here in England, there was some studies that looked at the effect of direct payments on discharges into residential care. Showed it had a positive effect on helping people leave residential care and helped to prevent new admissions. Over in the United States, in Florida, similar approaches meant people were spending less time in psychiatric inpatient and criminal justice settings and more time in the communities. There's a whole range of evidence that shows that it can and does work. So in that case, why has progress been so slow here in England? Because it has. If you look at the variety of studies, people with mental health problems, progress is slower than for almost other areas of society. Well, I'd suggest four main reasons, four problems we're having people need to think about. The first is locating leadership in the healthcare system. The NHS in England doesn't have personalisation as its major priority, and other things are getting in the way, and therefore the leadership isn't what it needs to be. Secondly, and linked to that point about the health service, there are tensions and a lack of clarity about the interface between personalisation and its expectations and other key policy expectations like risk management and payment by results. Thirdly, there are real problems about implementing such a cultural change at a time of financial cuts. I know, for example, of one occasion where people who use services and families received a letter telling them about this great new personalisation policy. 3 weeks later, they received another letter telling them of cuts of up to 50% in the services. It was obviously difficult to disentangle the two in their minds. If you put all those things into one, then what we're finding is that many people who use services are ambivalent about personalisation. Where they support it, they're strong supporters, but without strong endorsement from people who would benefit from such an approach, then personalisation is going to find it difficult to make significant progress, particularly in difficult financial times. So to help make this happen, one tool that we've developed at the National Development Team for Inclusion is a thing called Paths to Personalisation. We developed it initially for the Department of Health. We've now reissued it independently. And it was co-produced with people who use services, and it provides descriptions and explanations of what personalisation means for people, examples of how it has gone well, pointers to good practice, and crucially, this co-designed purpose. It's come from people with mental health problems in partnership with the professionals and the services that they support. And one of the ways in which we've written it is to write it in what we call I statements. So it's located in the outcomes that people want to achieve. It can provide a real flavour of what the outcomes from this new policy, well, not so new nowadays, are expected to be. There's a range of things in the contents, and I won't go through it all, but it talks about person-centred systems, about support for carers, inclusion, partnerships, leadership, workforce issues. You can find it on the NDTI website, and I'll put that web address at the end of this presentation so you can find it and look at it further if you want to. So what are we learning in England about what needs to happen if personalisation is going to work well? There are a number of things, and very briefly. Firstly, that person-centred approaches are absolutely central, but are they really understood? If you don't start with the person, get person-centred planning right, you don't have a chance of it working. Linked to that, support planning has to be the core of how you design what people want and need, but it needs time and it needs resources. It needs investment in advocacy and family support, but again, the investment isn't completely being made in this country at the moment, but it has to be a priority. There are some important concepts like supported decision making that are crucial if people are going to benefit, particularly for those where capacity is going to be an issue. And for everyone, brokerage as a mechanism and a way of finding out the really different service options that are out there is something that has to be invested in. But in the UK in particular, we find that brokerage is ceasing to be that radical, innovative resource that it was envisaged to be. Commissioners, local authority and the NHS, have to think more about place shaping. They're not going to have the role of buying the services anymore, so it's about how they ensure that particularly mainstream and community resources are out there that people can buy into to get the things that they want. The consumer is becoming the purchaser, and there's a new power relationship between them and services that people need to understand and learn how to work with. Workforce and market development are therefore important issues for commissioners to get to grips with. For providers, there's a significant reduction in the certainty of income that they have, so they've got to establish new relationships with personal budget holders, with people who use services, and think about how they operate with a greater degree of financial uncertainty in the future. For regulators, well, what do you regulate if people are buying new types of innovative community-based services and supports? Can you regulate those things? Should you? You risk stopping innovation and some of the creative things that are happening if things get over-regulated. Risk is something that particularly in mental health services we know is a challenge. If services are faced with a creative approach to personalisation or a fear of being hauled in front of the local press because something has gone wrong, the conservative approaches tend to hold sway. So we've got to have an approach that means that those who are perceived as most risky have the potential to benefit from personalisation. There are some practical things as well. You have to change your financial systems, you have to change your accounting systems, care management has to be different, the basic service systems need to be new. And for me, one of the most important things is how you bring the mainstream community resources alongside those of mental health and other services systems. There's a real risk that we will continue to operate in our silos of services and communities unless we do things differently. But the bottom line from all this is quite simple. The evidence tells us that if we do it well, then outcomes for people are better than they used to be. And that means we can't put the genie back into the bottle. That's not an option for us. People have had a glimpse, they've had a taste of having more control. Outcomes from traditional services were poorer. We know that, so we can't go back there because those outcomes just aren't good enough for people. For me, the challenge and the key question is how we can foster a real understanding of personalisation, a belief of what is possible, and give people an appetite to take organisational risks, particularly at difficult financial times. Because unless we have the courage to do those things, then personalisation risks being something that is not delivering on all that it promises. And what we know, the evidence tells us, is that when it delivers well. Thanks a lot.